You say. Shall I start, Mahmoud, or you're going to?
Okay, can we start now?
You are ready whenever you say.
Okay, Regis, how are you?
Dr. Higgins.
Yes, whenever you want.
Are you ready?
Yes, yes.
Okay.
Seems that there are some minutes left. It's
Okay.
If you want to wait for more people to attend, you're
Okay.
free.
How many people joined, Dr. Mahmoud?
Up to now, we have 11 attendees, and in addition to us, 11 attendees.
Okay, but you told me the number was many body.
Yes, we have more than 160 registered, but I'm not sure that all of them actually will join. You know, when you have a chance to register, you register, and later on you can see your agenda. So we are having 160 registered, but I'm not sure if they all will join actually or not.
They're not joined. They don't join. Dr. Regis, your talk today is going to be about the tips and tricks about the therapeutic reduction, and it's going to be an educational one.
Yes, I will talk about therapeutic mammoplasties. I brought some video clips, some tips, some indications, how to manage some complications.
Okay, perfect. And I heard about your innovation about the geometric compensation.
Yes, I'll have the opportunity to show you today.
Yeah, very good. Okay.
Very good. We are looking forward, yes.
And when before the workshop started today, the webinar today, I wanted to say hello. I thought you're going to say hola. Hola, is it applies in Portuguese also like Spanish?
No. In Portuguese it would be oi.
Oli,
instead of hola.
Hola, Spanish. Okay.
Yes.
What about the Oncoplastic Academy there? How many surgeons apply to your academy in Brazil?
We organize some courses, some hands-on courses, and it's the 7th year that we organize it. And every year we have a lot of surgeons that come every month to our cities, and we also organize some congresses. There is the commit that it's also a hands-on course in cadavers and pigs. And last year we didn't have because of the pandemic, but the other year there was 50 people from half of them were from other countries and half from Brazil. There are many people from Latin America that used to come, and also last year we had someone from Greece that came also to the course.
Perfect. How did the founders of this academy had their training? As I heard, so for example, the Turkish school, most of them they learned with Dr. Aldrich and with Dr. Rizai.
Yes.
Most of what's your training?
I was trained by a plastic surgeon in Brazil, but then I went to Europe. I went to Italy with Myro Riches and Professor Petit, and then I went to Werner Aldrich also.
Okay, Professor T at Milan.
Yes, in Milan.
Okay.
Yes.
Dr. Regis is originally Brazilian, I think.
Yes, he's a great friend.
Yeah, it's very interesting. I've been there to their workshop several times. I attended them in June at Milan. They were very nice.
Yes.
And it was very interesting. The group is very good.
His next course will be next week, actually.
Really?
Yes.
It's going to be also on Zoom?
Yes, everything virtual. It will be a web platform, and there will be live surgeries. It will be next week. It starts on Thursday.
Okay, you are going to participate in this webinar?
Yes. I will be one of the debaters.
Yeah, perfect. The last time I attended the workshop, it was all of it. It was operative.
Yes.
The last one I attended, when Dr. Regents took over after Dr. Petit. He made the workshop, all of the workshop, only no theoretical talkings. All of them were operations.
Yes.
Okay, we can start if you are ready.
Okay.
What about Dr. Mahmoud?
Yes. Can we start now? Okay, Dr. Regis, Dr. Ahmed, Dr. Tariq. Okay. Good evening, all. On behalf of Alexandria Medical Training Center faculty, it gives me much honor to welcome you to the first breast surgery webinar among Alexandria Medical Training Center group of webinars titled AMTC Web School, which is a free online series of webinars in different branches of medical and surgical specialties, launched and powered by Alexandria Medical Training Center. Alexandria Medical Training Center is the official training platform of Faculty of Medicine of Alexandria University, and you can follow our activities on our Facebook page and on our official website, which will be launched very soon, hopefully. My name is Mahmoud Al-Husseini. I'm MD, PhD, Associate Professor of Surgical Oncology, Faculty of Medicine, Alexandria University, Egypt, Vice Head of AMTC, and will be responsible for the breast division webinars. In the breast surgery webinars, we shall carry a monthly webinar with an international guest speaker discussing one of the fields of breast surgery, including malignant, non-malignant, as well as aesthetic topics. Our guest speaker will give us a 45 to 60 minutes presentation and will allow for 15 minutes discussion by the end of the presentation. So kindly you can submit your question in the question and answer section. Now let me welcome you again to this first webinar titled Therapeutic Reduction Mammoplasty Tips and Tricks, presented by our guest speaker and my dear friend Dr. Regis Paulinelli from Brazil. And I'm honored to have two chairmen for this webinar, Professor Ahmed Tariq, Professor of Surgical Oncology, and one of the eminent breast surgeons in Alexandria and Egypt. He was the ex-head of Surgical Oncology Unit, and again, he was the previous head of Surgery Department as well. Also, I'm glad to have a co-chairman, Professor Tariq Al-Fayoumi, Professor of Surgical Oncology, and the current head of Surgical Oncology Unit, and one of the interested surgeons in the field of breast surgery. Now, allow me to leave the platform to Professor Ahmed Tariq to introduce and welcome Dr. Paulinelli to start this webinar. Yes, please, Dr. Ahmed.
Thank you, Dr. Mahmoud. It's my pleasure to introduce, I think it's called Regis Paulinelli, Dr. Regis Paulinelli, right?
Yes.
He's a well-known breast and oncoplastic surgeon. He works at the Federal University in Joyous. He's the Vice President of Oncology Department of the Brazilian Society of Mastology. He's also a co-founder of Oncoplastic Academy and a reviewer of many journals and an author and a co-author of many scientific papers and book chapters. Dr. Paulinelli also is an author of textbook of oncoplasty and breast reconstruction in Brazil. He conducted and led many workshops and hand-on courses on oncoplastic surgery, organized by the Brazilian Society of Mastology. Definitely, it's an honor that we have him today among us. He's going to present his talk about the therapeutic reduction mammoplasty. It's going to be an educational one, and he's going to talk us about the tips and tricks and how to mark and what are the complications. And I think you are going to have a very fruitful meeting today. This meeting is made in collaboration with the Alexandria Medical Training Center Web School, and it is in collaboration with the Oncoplastic Department of the Brazilian Society of Mastology. And this is considered the first breast surgery webinar. Dr. Paulinelli, you can start, and you're welcome, definitely.
Thank you very much. I'm very honored to be here with you. I'll try to share my screen. Yes. Okay.
Perfect.
Yes.
It's clear now.
Okay. As you said, my name is Regis Paulinelli from Brazil. I am a mastologist. I work at a public university and at a high-volume cancer hospital here in Brazil. Interestingly, unlike many countries, here in Brazil, mastology is a fully independent specialty, and it includes breast surgery, either aesthetic, reconstructive, or oncologic surgery, but also breast imaging, clinical treatment, depending on the specialist interest. It's really a pleasure and honor being here in Egypt again. Many thanks for the organizers, and especially to Dr. Mohamed El Husseini and Professor Galal and the University of Alexandria for the invitation. I haven't known Egypt personally yet, but I had the curiosity of making a virtual tour, and Alexandria is beautiful, really amazing. Congratulations. In the next hour, I'll try to summarize the most important points, in my view, about the therapeutic mammoplasties. I don't have any conflicts of interest to declare. Well, for tumors up to 5 centimeters, we have enough level 1 evidence to say that conservative treatment is equivalent to mastectomy. Here you may see 6 big randomized studies. NSABP 6 was the only one that required free pathological margins, but all the others together, local recurrence and survival were similar in quadrantectomy and in mastectomy. In Brazil, we still don't have a national breast cancer screening program. We still have many cases of locally advanced breast cancer, I think, like in Egypt and many other countries in the world. More recently, I'm very interested in expanding the indications for conservative treatment through neoadjuvant chemotherapy and extreme oncoplasty. Indeed, it seems to be a safe strategy. We don't have randomized trials, but we have much level 3 and level 2 evidence. I invite you to read our systematic review on this topic. The only real limitation for conservative treatment is our ability to leave behind a good cosmetic result and a good symmetry. There are some real patients that came, some real patients that came to our service referred by other surgeons for delayed reconstruction after a conservative treatment. You can see sometimes conservative treatment can left behind a very bad result. It's not appropriate. The two main tools that we have available for increasing the indications for conservative treatment are neoadjuvant chemotherapy and oncoplastic surgery. When I was learning oncoplastic surgery, my masters taught me that by knowing these three techniques, we could solve more than 90% of the cases. A superior pedicle for tumors in the lower quadrants, an inferior pedicle for tumors in the upper quadrants, and a round block mammoplasty for breasts with limited pitosis. Otherwise, a mastectomy would be necessary. That was what I learned in the beginning. Actually, there are many other techniques. A very well-known classification for oncoplastic techniques is this one, of volume displacement and volume replacement. For big breasts or small tumors, we may use a volume displacement technique, like a mammoplasty for example, or other glandular flap. And for small breasts without ptosis or for big tumors, we may replace the volume from tissues outside the breast. I would like to emphasize why it's so important to try a conservative treatment instead of a mastectomy after all. We are creating a database of our patients that have completed all stages of breast reconstruction and returned to our office after at least 6 months of surgery or radiotherapy. In this partial analysis of 567 patients, partial breast reconstruction that was on oncoplasty led to much better satisfaction using the breast Q, much fewer complications at the same rate of local recurrence as mastectomy, and with a smaller number of surgery. Everybody can show beautiful results at conferences, but nobody wants to show complications and bad results. Capsular contracture after radiotherapy, skin necrosis, infection, loss of implants. Much more research supports the same conclusion. It's much better to do a partial than a total breast reconstruction, whenever possible. Although my masters taught me that by knowing mammoplasty techniques we could solve more than 90% of the cases, looking back at my data, of this partial analysis of 284 cases of partial reconstructions, if I had only known conventional mammoplasties, I would have doubled my case of mastectomy. I've been always eager to learn as much as I could about anything that could help my patients. Mammoplasties are just one type of volume displacement technique. You may see that I try to use as much alternatives as possible. You can see a lot of different techniques listed here. And in some cases I had to use a personal type of mammoplasty called geometric compensation that I'll have the opportunity to show you today. For therapeutic mammoplasties, the most common procedure is to use Wise pattern or inverted T. But there are many options for reducing the size of the scars, reduced horizontal branch, L or J scars, vertical mammoplasty or Lejeune technique, perioral mammoplasty. Usually it depends on the amount of skin sagging. I'll show you a case of a superior pedicle. In this case, a superior supermedial pedicle, which is a variation that I use more often than the superior pedicle. She was a 48 years old patient, slight obese, with a palpable lump, 2.5 centimeter palpable lump, willing to correct breast ptosis and asymmetry. How we do the markings: I first mark the A point. The areola is 2 centimeters above. I mark 3 centimeters for each side to delimit the areola. It's a pre-marked way of doing the markings. This is the Wiesenberger maneuver, in which we estimate the amount of sagging skin. Then I check for symmetry. I used to let a 6 centimeter pillar in each side, vertical pillar, 4 centimeter areola marker. Then we start to deepitalize around the areola and all the pedicle area, the skin incision. For obese patients of high risk of complication patients, I used to let this small triangle in the inframammary fold to reduce the amount of tension in the suture. Here the Schwarzman maneuver, it's the depitalization of the pedicle. And then I start to do the pedicle itself. You can see that the vascularization comes from the internal mammary vessels. I let all of them preserved. And then you have the pedicle. Here you can see better how it works. And in this case, I led also a deepitalizing inferior pedicle, that it's called here in Brazil Liacir Ribeiro's technique, in which we we'll add some depithelize inferior pedicle to have more volume and projection. I'm doing the lumpectomy. You can see the lumpectomy. I put some stitches to facilitate the pathological assessment. The sentinel node biopsy. Usually I use the same incision. You have a very big incision. I fix the inferior pedicle to the chest wall to avoid the weight of the inferior pedicle can stretch the skin and recur the ptosis with time. I always put some metal clips to orient the radiation boost. It's something important. Here I'm doing the approximation of the pillars of the mammoplasty to increase projection. And then the wound closure. It's very important that we don't have any tension in the sutures, because if you have too much tension, we'll probably to have a dehiscence or enlarged scars, and it's a very important step. Now the contralateral symmetrization. We use the same technique, the supermedial pedicle. Here the approximation of the pillars to increase projection. Here 2 months after surgery. And it was a 4.5 centimeter tumor actually, with 3 margins, 1 positive lymph node out of 3. She had a high risk mamma print, and she went to chemotherapy and then radiotherapy. And you can see the results 6 months after chemo and radiotherapy. The most common technique for therapeutic mammoplasty for oncoplasty is the inferior pedicle, because most of the tumors are in the upper poles. Here how I do this technique. She had also 48 years old. She had a 5.5 centimeter tumor. It was a luminal B. She did a neoadjuvant chemotherapy and had a 3 centimeter residual palpable lump. It was a small breast, but still it was possible to excise the tumor. The A point, as I showed you, the Arella, the Bisenberger maneuver, how to estimate the skin sagging, and the final preoperative markings. In this case I left this small island of skin because I wasn't certain that the nipple would be free. Maybe I was afraid that the tumor would compromise the nipple and Arella complex, and so I left this small plug flap to replace the nipple Arella complex if I had to remove it. And here doing the depithelialization. And then we start to do the inferior pedicle. Usually I don't. I usually only let 8 or 6 centimeters wide inferior pedicle. But in this case, because the patient had a very small breast, I decided to let all the lower glandular tissue attached to the inferior pedicle to preserve the breast volume. I didn't want to reduce the breast too much. I only took off the tumor and nothing else. And starting to do the lumpectomy. I can feel the tumor between my fingers, and I take out all the tumor with free margins. Sometimes I use the frozen sections for intraoperative assessment of the margins, but not always. And you can see here the lumpectomy specimen, and I used also the sentinel. I used the same incision for the sentinel node. I used a double localization, with patent blue and also radio guided localization, because it was after neoadjuvant chemotherapy to reduce the false negative. Here the metal clips for the boost, for the radiation boost. I always attach the base of the pedicle to the chest wall. The tip of the pedicle I don't attach it, because if we do this, we have the contrary of our intention, that is to increase projection. And the objective to attach the inferior pedicle to the chest wall is to prevent the recurrence of ptosis over time. How we do this in a schematic view. Sometimes when I do these stitches, we have some retraction in the inframemory fold, and we have to release it a little bit. And here doing the approximation of the pillars to increase projection to have a more beautiful breast, and then the wound closure. The same as the other surgery. And now we start to close everything, to close the nipple and areola complex. In this case, the frozen section showed that the areola was free, and so I deepitalized the plug flap. Here the result 1 month after. There are other mammoplasties trying to reduce the scars. The Lejeune mammoplasty has only a vertical incision. The lower pole is excised and the pillars are approximated or crisscrossed to increase projection and rebuild the breast. It's an excellent technique for tumors at the lower poles, but there are modifications to allow it to be used in any other quadrants. In my website you can see other examples that can be used in other quadrants. The resulting technique is a modification for central tumors, in which we let a small island of skin to fill the defect, as you see here. There were already several proposals for periareolar mammoplasties, with the inconvenience of enlarged scars and enlarged areolas. The most popular technique was proposed in 1990s for a French surgeon called Benelli for aesthetic purposes, with the aim of better correcting ptosis and preventing the enlargement of the areola and scars. This is the original markings of Benelli. The A point, that is the projection of my finger in the inframemory fold that I showed in the video. The upper edge of the areola is 2 cm above. Point B is the lower edge of the skin resection and should be between 5 and 12 centimeters from the inframemory fold. Point C and D corresponded to the lateral and medial limits of the skin resection, equidistant from the memory meridian in the A point. Point D should be between 8 to 12 centimeters from the midline, depending on the size of the breast. My personal preference is just to position the A point and not to move away too much point C and D, because there is much more tension in the horizontal direction. In the original technique, a superior pedicle for the areola nutrition is maintained. In the oncologic adaptation, you can open 360 degrees and maintain the central vascularization of the areola. My preference, although, is to open and take off a little as possible. I usually only undermine as little as possible because of the risk of fat necrosis. And I only use this technique in small breasts, almost without ptosis, and with more glandular tissue. I don't use this in fatty breasts because there's more risk of fat necrosis. I almost always do a contralateral symmetrization. Here you see a case of round block mammoplasty. I'll show how I do. The patient, she was a 42 years old patient. She had a former mammoplasty with asymmetry. She had a bigger right breast, also a bigger areola. She had a 4.5 centimeter tumor, a luminal B tumor. She did a neoadjuvant chemotherapy, and with a partial response to the chemotherapy. Here are the markings as I showed you. The points A, B, C, and D. And now I start to do the deepitalization of the areola and also the circle around the areola, the Schwarzman maneuver, the deepitalization of this circle. Here I'm doing the undermining, the skin undermining. It's part of this technique. It's like a mastectomy. We split the glandular tissue from the skin, but only in the area of the tumor. I don't do the 360 degrees undermining because otherwise we would have more risk for fat necrosis. And to do the lumpectomy, it's important to do it in a vertical way, radially, so that we have two pillars that we can approximate. I'm doing some markings for the pathologist, and then the quadrantectomy specimen. In this case, this was one of the exceptions that I didn't do the contralateral symmetrization because she had actually a bigger breast in the right. The radial suture of the pillars, we always resect it in a vertical way and approximate the pillars, the remaining pillars. And the name of the technique comes from this suture. It's called Benelli or round block suture. We use an inabsorbable, non-absorbable thread, in this case the Perleni. It's not a subdermal suture. It's a little bit more deep than a subareolar subdermal suture. Otherwise, the thread could be apparent by transparency through the skin. And so we do a 360 grades suture, like you see here in the picture. And we can choose the size of the areola. This prevents the enlargement of the scars and the areola. We choose the size that we want and do a suture. And then we do the subdermal and intradermal sutures. Sutures and then the intradermal sutures. And we're ready. In here after 2 weeks and after 2 months. After six months of the radiotherapy, and still a good symmetry. The areola is the same size. We can choose the size of the areola. In very large breasts, I use the thorac technique, in which the nipple areola complex is amputated, and we do a free graft of the areola. In that case, one of the nipples were involved by the tumor, and I used the other side to rebuild both sides. Sometimes I use this plug flap technique. The plug flap has been developed by Dr. Dyer, a plastic surgeon in Brazil. You let a skin island vascularize by the inferior or superior pedicle to fill the defect. It's very useful and interesting, especially in the meridians of the breast. It has a high risk of necrosis if you compromise the pillars of the mammoplasty, or if you have many parallel skins, like in this case. You have to be very careful where to put this island of skin. Thinking on this complication, on these problems, especially when the tumor is too big, when we have to take off the skin, when it involves the pillars, I thought of the geometric compensation. The objective was to allow an extensive skin resection of the tumor for large tumors near the skin, or that involve the skin. In this technique, we save the lower triangle, usually excised in the Weiss pattern, and transposed it to the tumor area. This patient, for example, had a 6.5 centimeter tumor in the upper inner quadrant of the right breast, with thickening of the nipple and skin, without response to the neoadjuvant chemotherapy. Instead of removing the lower triangle, we excised the geometrically equivalent area over the tumor. At the end, we had this Z or S-shaped scar instead of an inverted T. She never wanted to rebuild the nipple, but the symmetry was very good 6 months after chemotherapy, or even after 10 years. We first published 17 cases like this in the Journal of Surgical Oncology in 2014. Last year, we published 73 cases, including some variations and evolutions of the technique. It was an honor because the technique was chosen to be the back cover of the newspaper. I invite you to read it. In this last publication, I published also some modifications to improve the results of the technique. Here how I do the geometric compensation. It's better to understand if you see the technique. It really opens the possibility of a breast conservation in very difficult cases. The patient was 42 years old. She had a triple negative tumor with skin retraction, with bloody nipple discharge. It was a 13 centimeter tumor without response to the neoadjuvant chemotherapy. It was in the upper medial quadrant. That is a very difficult quadrant to rebuild. Very difficult case. And you see in the mammograms that she had an extensive area of microcalcifications coming from the nipple to the involving the skin and all the upper medial quadrant. Here the markings is the same as the other mammoplasties. The A point, checking symmetry. Here's the area of the tumor and the nipple that was involved. The referential line, that is the meridian of the breast, is more or less 10 centimeters, but in the geometric compensation, I place it 1 centimeter to the other side because the scar would retract a little bit the nipple, and I place the nipple 2 centimeters to the other side because of the retraction. Here the Wiesenberger maneuver. In this case, I'm using a post-market areola. I didn't mark the areola so far, but I will do in the middle of the surgery. In this case, I let a 9 or 10 centimeters pillar from the A point. It is 6 centimeters from the border of the areola, but it's 9 centimeters or 10 centimeters from the A point. With this green marker, I'm showing the area of the tumor. Here, diagram. We only move the triangle. Instead of taking the triangle in the lower poles, you excise all the triangle over the tumor. The rationale is very simple. It's very easy. The green line is the area of resection. The quadrantectomy specimen was 261 grams, a very big one. And I didn't took anything else because the breast was not so big. The other inferior lower triangle, I only deeptilized it. Here I'm doing I had to do axillary clearance. I used the same incision. I'm deeptilizing the other inferior quadrant, inferior triangle, not to reduce too much the breast. And then I close everything, the vertical pillar, closing the defect. I close also the glandular tissue. I place some metal clips to orient the radiation boost, like I did in the other case. And I just close it. It's very easy. If you understand how to do it, it's a very simple technique and very useful. As you see here, it would be very difficult that anyone would do a conservative treatment in this difficult case. Here the areola is 2 centimeters to the other side because of the areola. In this case, I used the part of the other nipple in the areola to do a free grafting. I harvest part of it to do a free graft. Here the free graft of the nipple and then the areola. And we place a compressive dressing after it for at least 7 or 10 days. And just closing everything, the contralateral symmetrization. And here's the result after 1 month. And the result was very good. I recently saw her. She has almost 5 years, and the result was perfect. After more experience with this technique, some variations appeared, such as this one aiming to result the visibility of the scar, called inverted geometric compensation. Instead of transferring the entire lower triangle to the tumor area, we transfer, on the contrary, we only transfer the defect of the pillar to the lower triangle. There's this other variation, the double geometric compensation, in which the 2 lower triangles were transposed into the tumor area to allow a very extensive resection. In the other case, we had to combine a geometric compensation with a plug flap from the skin to the inferior pelvic to remove a 14 centimeter tumor which infiltrated the skin in the upper medial quadrant. To avoid a more visible scar in the upper quadrants, in some cases in which the skin doesn't appear to be compromised, but in which geometric compensation will be considered to avoid the skin necrosis, we thought of this variation, the disguised geometric compensation. We excise the gland, preserving the skin over it, and hold it attached to a lower triangle to increase vascularity by means of the perforating branch of the intercostal vessels. So far we have 25 cases of disguised geometric compensation. Fortunately, very few complications, 95% with good or excellent results using the rarest scale in the software BCCT. Here are some results. We are preparing our data for presenting at the Brazilian Breast Cancer Symposium next month and for publication this year. A very important tip. It's better to plan a partial reconstruction in advance and do it immediately along with lumpectomy. Dr. Krishna Clough from France showed that if you must operate on irradiated breast, the complication rates increase 3 times and the poor static results 4 times. In irradiated breasts, we try to avoid undermining. In some cases, I avoid operating at all. Usually we just reposition the nipple to a more central position or make a small skin adjustment, revise large scars, and correct small retractions with fat grafting. As in this case, we increase the volume and correct retractions with lipofilling and in the right breast and made a contralateral reduction. That's the result after 1 year. The profile of complications in mammoplasties is very favorable. The most common complication was dehiscence in 11% of the cases, but large dehiscences like this one of more than 20% of the suture is very rare, only 0.4% of the cases in our cases. The riskiest point are the junctions of the inverted T and areola. For these riskiest patients, I try to resect less skin and sometimes I leave a small triangle at the points of greatest tensions, as I showed in the videos. Dehiscences are usually related to too much tensions in the suture or infection. Treatment of dehiscences, usually with dressings. We did a new suture in only 3.6% of the cases. It's important to keep in mind that we should prevent delay in the adjuvant treatment, and so sometimes we do a suture to prevent the delay. Areas of fat necrosis occurred in 9% of the cases. In this first case, you may see a quadrantectomy with glandular rotation, which seems to have an excellent result after a few months, but had a very bad result several years after radiation therapy. In this case, you can see a Lejour technique vertical mammoplasty, which is a technique that uses a more extensive skin undermining to reduce scarring. It had a good result at the start after radiation therapy, but an ugly retraction and asymmetry after a few years. Fatty tissue is poorly vascularized. In fatty breasts, I try to choose a technique in that you won't need to undermine the skin from the breast tissue, and as in this case. I've just changed the position of the nipple areola complex and it was enough to have a good symmetry. I invite everyone to the Brazilian Breast Cancer Symposium. It's a congress that we organize here in Brazil, in my city. It's the biggest congress in Latin America on breast cancer research. Oncoplastic surgery is also in the spotlight in the Congress for you that like oncoplastic surgery. We're celebrating the 10th edition and it will be fully virtual this year due to the pandemic. We will have simultaneous translation into English and Portuguese. You can find these video clips that I showed and more than 100 other educational videos on my personal website. I created the website at the beginning of the pandemic to help colleagues and alumni interested in oncoplasty. After less than 1 year, more than 3,000 surgeons around the world are using the website. I was so glad that I could contribute in some way. Here's the address. You can take a picture. You can also scan the QR code if you prefer. It's totally free. Thank you again very much to Professor El Husseini and Professor Galal and all the debaters for the invitation and the opportunity to be together with you today.
Thank you, Regis, for sharing your experience with us. Actually, this is a very nice illustrative presentation, as elegant as usual. I'm sure our chairman will have some comments and as well as some questions from the participants. So please, Dr. Ahmed Tariq and Dr. Tariq, kindly share the questions and your comments with our guest speaker.
Well, I think we can start with Dr. Tariq. He's going to pose the questions first. Start with asking the questions. Dr. Tariq.
I want to raise two questions. First of all, I would like to thank Dr. Regis for his nice presentation. I want to ask two questions. So, first, you mentioned that you don't often use frozen section in your work. What is the indication of using frozen section, and how often used?
Yes, frozen section is very popular in Brazil. There are some cities, some parts of Brazil that they use frozen section in every case, but it's expensive, time consuming, and we had very few cases of positive margins. In our technique of geometric compensation, we only had 2% of involved margins. If I'm very sure that I'm taking the tumor with very big margins, sometimes I don't do frozen section. If I'm trying to spare as much as I could, because I think there will be a static defect, and I take the tumor very close to the margins, then I use the frozen section.
Yes, sir. We in our department we use imprint cytology sometimes instead of frozen section. Do you use this technique, or it is not available?
Yes, it is. It is. It is available in some, not elsewhere in Brazil. In my city, yes. In my service, yes. But not all surgeons have this opportunity here in Brazil.
My next question is about how many patients they agree to do symmetrization of the other breast in the same session.
Yes, we always talk to the patient beforehand if she wants to correct ptosis, because there are many other techniques in which we don't change too much the shape of the breast. There are other oncoplastic techniques, or even a small quadrantectomy depending on the size of the tumor. If the patient doesn't want to touch the other breast, it's okay. But women in Brazil have a lot of vanity. I don't know if it's only in Brazil, but they usually are very glad if we offer the opportunity to correct ptosis. Usually they want to touch the other breast.
Okay, thank you. I will leave the question for Professor Ahmed Tariq. Would you please?
Dr.
Thank you.
Regis, it has been a wonderful presentation, and actually we had a lot of questions because many of the attendees wants to elicit some important points, technical points. I'll start by giving you, starting with the therapeutic reduction. If I'm going to choose between the inferior and superior pedicle, is there a cutoff point between the suprasternal notch distance to the nipple, at which you can say you'll never use the superior pedicle and then you're going to embark on doing inferior pedicle?
Yes, the problem with the superior pedicle is that if you have to move the nipple and areola complex too high, maybe we have some difficulty to place it there. We can always change our mind. If you try to do a superior pedicle in the middle of the technique, we see that we can't reach where we want, we can amputate the nipple areola complex and do a free grafting. This is a very popular technique in Brazil, but I personally, when I envision that it will be difficult to place it, we don't have a cutoff. Usually it's 10 centimeters, but maybe we have difficulty in 6 centimeters sometimes, or in sometimes we can reach the point with 12 centimeters very easily, and it's difficult to establish a cutoff point. But if we try to do a superior pedicle and you see that we can't do it, we can always move it to the free grafting. What I do is when I envision the difficulty beforehand, I don't do the superior pedicle, I do the superomedial pedicle, as I showed you. The superomedial pedicle is much easier to place the nipple to the right position.
And how far you keep the thickness of the pedicle for superomedial one? How much the thickness of the pedicle?
Oh, I don't have this cutoff point, but easily with 20 centimeters maybe, it's very easy to place. Only in those very big macromastias we do the thorac technique.
Okay. Another question is regarding, you're not afraid to do a nipple grafting? Suppose the patient is going to have a post-operative radiotherapy, and you don't feel that the projection is going to be affected, the pigmentation of the nipple and the areola is going to be affected by this. And how far is the results are good in your hands in this thing?
Oh, the free graft of the nipple areola complex is the most beautiful way to reconstruct the nipple areola complex. There isn't any tattoo or micropigmentation or CV local flap. There isn't anything so beautiful than the nipple areola complex. But there are some problems. There are cases of necrosis. Usually it's superficial. We let it 1 month, 2 months, and a small part of it is fall down, and the other part is there, and we don't lose all of it usually. And there can be also some areas of dyspigmentation. That's the problem. But it's a very good way of reconstruct the nipple, especially in those ones with very big nipples. In this case, it's very difficult to reconstruct, to do a CV flap, for example, and have a very projected nipple. It's better to reduce the other side.
Some questions about the round block techniques. It's about the purse string suture you use. You use non-absorbable suture.
Yes.
Some is asking about, do you have an experience with the V-look suture, for example? What kind of suture material you use? Is it Prolene, and what O?
I usually use Prolene or nylon because they are non-absorbable. If we use absorbable sutures, there is a big higher risk of enlarged scars and enlarged areolas. And so it was a very important landmark in the Benelli technique, because before that many other authors used to do periareolar mammoplasties, but the problem was the enlarged areolas and enlarged scars. And because of the Benelli suture or the round block suture, it becomes to be widespread.
Dr. Tariq, you have some questions for Dr. Paonelli? Dr. Tariq?
No, thank you.
Okay. Can I ask more questions if you are not?
Yes, please.
He gives experience and.
Okay, I want to have another. I have a eager question. If you have about the second breast conservative surgery, how much you do it in Brazil? This is my first question. And the second question, how far you do multicentric tumors? Do you feel it safe to do it with therapeutic reduction? Because I myself feel when I do tumors in different quadrants, I think there is something, a potentiality of the breast tissue. It might have something we don't detect by imaging, that in between the two resected masses, there might be something. Do you only rely on radiotherapy on this? You feel safer to do this technique in multicentric tumors?
Yes, these are two difficult questions to answer, but I'll try. The first one is a re-lumpectomy, a new lumpectomy after radiotherapy, if I understand properly.
Yes.
Yeah. I don't do it very often. By coincidence, last week I did one, but with intraoperative radiotherapy. We have it in our center here, and with intrabeam, it's more easy to do re-irradiation. If we don't have the opportunity to re-irradiate the breast, there is a higher risk of local recurrence, and so mastectomy would be preferred. The biggest series in the literature is one of the European Institute of Oncology of Professor Oreste Gentilini of less than 300 cases of re-incision of requadrantectomies. And there was a 36% of recurrence in 3 years. It's a very big number. He only had less than 10% of recurrence if the tumor had less than 2 centimeters. If it were luminal, in that time they didn't use this terminology luminal. They only said positive estrogen receptor, and if the time to recurrence is more than 2 years. In this case, they had less than 10% of recurrence, but the risk of recurrence after mastectomy is not low. It's more than 10% also.
Yes. Mm-hmm.
Yeah. And for the second question, it's about the. Sorry, it was the
multicentric.
The multicentric tumor. Yes, yes. Whenever we can remove all the centers of the tumor, all the foci, I think it's safe. We don't have too much evidence. The biggest evidence is a multicentric European research by Professor Madi Reisley, with more than 600 patients with multicentric tumors, operated with conservative treatment after neoadjuvant chemotherapy, and they had a very good result. I think it's safe, but we don't have level 1 evidence. I use it when I see that I can remove all the foci. I do it.
Okay, I think Dr. Mahmoud has many other questions he can pose to Dr.
Yes, please. We have, because of the very much interesting topic, we have many questions. Most of them are technical. In the large-sized breast, you know, in this wise pattern type of incision, we have the risk of having these lateral dog ears at the lateral end of the scars. A question about how to prevent lateral dog ears in mammoplasty.
Yes, usually we don't have to extend too much the incision if we try to compensate the dog ears with stitches. There are more tissue in the pillars of the mammoplasty than in the inframammary fold, and so we have to take the stitches more spaced in the pillars and more close to each other in the inframammary fold, and so we compensate the skin.
Suture, yeah.
Yeah, we compensate the skin, and usually we don't have to extend too much. But in some obese patients or patients with very sagging skin, sometimes it's important to extend the incision to remove all the dog ears. It's very bothering for the patients.
The question is the geometric compensation. The question says, do you de-epithelize the lower pool in the geometric technique, or you keep skin to compensate for the skin defects over the area of resection?
No, I don't de-epithelize it. I just let it there. I remove the tumor and don't remove anything, not the skin, not anything from the lower poles. And then the lower pole compensates the area of resection. It's the classic technique, but there are some variations that I showed you.
One last question, I'm not sure it is related actually to mammoplasties or not. Speaking about your favorite technique for uppermost inner quadrant tumors, the area, very challenging area to reconstruct, the no man land, as we call it. Yeah. What do you think for this?
Oh, if you don't have to remove the skin, it's easy. We can do an inferior pedicle mammoplasty that has beautiful results. If we have to remove the skin and the patient wants to compensate the ptosis, we can use the geometric compensation as I showed you. It was a case of a tumor, a very big tumor in the upper inner quadrant and in the central quadrants. And so it's possible to do it. But there are many other techniques like the Burroughs triangles, the thoracolateral flap with compensation in VY. There are other techniques that could be used, especially if the patient doesn't want to touch the other breast. There are other options.
Any more questions Sherman would like to share with our guest?
Perfect. I think we made you tired for the presentation and the questions. A lot of questions. I think it was going to be an endless meeting because it's very interesting, and you opened very important points, especially the geometric compensation. Thank you very much. We congratulate you very much for your talk. It was a marvelous presentation.
Okay. By this, we come to the end of this fruitful webinar. I would like to announce our next meeting on the 20th of May, 7 p.m. Cairo local time. Our guest speaker will be Dr. Zoltan Matrai from Hungary. He will be speaking about advanced oncoplastic procedures such as the retroglandular and the intramammalian and the Rhinopay techniques. And the invitation link will be available on our page very soon. Allow me to thank Dr. Baronelli and Dr. Ahmed Tariq and Dr. Fayumi for this nice time, and special thanks to Dr. Baronelli for sharing his experience. Thank you all, and see you on the 20th of May, inshallah. Thank you, Regis. Thank you all.
Thank you very much. People are asking here in the chat if the webinar is being recorded, and you told me that we'll put in your website, and I will put in my website also to answer the.
Hopefully. Yes, so it will be available in our Facebook, on our website, which will be launched within a few days, and will be available on the webpage of Dr. Regis. We agreed upon this before we start the webinar. Yeah.
Thank you thank you very much for the opportunity to be here. It was really a pleasure. Really a pleasure to make new friends and to get to know you all.
Maybe one time you have you in Egypt and Alexandria especially.
Hopefully, I appreciate it. Thank you.
Okay. Thank you.
Bye-bye.
Bye.
Thank you. Thank you.
Be safe, everybody.
Physically.